Thank you, Lalit. So I'm taking on 3D vitrectomy for proliferative diabetic retinopathy, and as Lalit suggested, we'll go for the videos directly. So I'm using the artevo. I don't have any financial interest, and I think the advantages, there are a lot of advantages there, but this is what advantages to teach the entire operating team, your fellows, the nurse, the anesthetist, and I'm just showing you a pre-op diagnosis with the proliferative diabetic retinopathy with vitreous hemorrhage, actually in both eye. So you can see a 25 gauge vitrectomy being done, and after clearing the vitreous hemorrhage, you will see the fibrous tissue which has a traction. So clear the tangential traction, clear all the, you can see the, it has been lasered well, and there was only a traction on the disc on the nasal side. You can see the sclerosed vessel. So this is a problem with the diabetic patient where they don't come follow up regularly, or they come late. So I think that's the reason you have to screen, diagnose and treat, and we saw the medical treatment, the all that will be there. But I remember Peter Hamilton said we'll do a wonderful laser and we can prevent proliferative diabetic retinopathy. It doesn't happen, and I think still we don't know what is the cause. Now AOS is doing a study. You can see all the traction released, and then we do a fluid air exchange and complete the fill-in pan-retinal photocoagulation. And this is around, there's a traction and with the break which we saw, which is in the nasal side fortunately, and finally you can see we injected the accentrics at the conclusion because we have removed all the traction. And this is the pre-op and post-op picture where you see the disc pale but vision is 618, pressure was maintained. So other is the PDR with a severe fibrovascular proliferation. You can see the severe proliferative diabetic retinopathy patient comes to you like this with a counting finger close to face. And I always tell them when you operate, you're touching the, like you're playing with fire, you can get burnt. So that's what I think I take informed consent. I spend a lot of time pre-operatively talking to them. I tell them nothing to talk post-operatively. The reason is 1 out of 100 can develop neovascular glaucoma in case the things are not done well, and that's what I want the patient to know. And in case, I mean, you do a wonderful clearing of the vitreous hemorrhage, the traction, and completely pan-retinal photocoagulation. So I am now covering temporally and going ahead, and now nasally. So we have to do extensive. Now after completing the laser, I am now releasing the traction on the disc, and you see he said 2B's breaks and the bleeding. So I think that's more important to clear. You can see in spite of all the things, there is a break happened. So you have to identify. So both has happened, bleeding and blood. And finally we did a endolaser photocoagulation around the break and the then use the oil. This is the post-op picture. And then you also have a combined traction retinal detachment. You see here severe proliferation with the combined, and you will be seeing this is a totally like a disorganized retina because of the patient comes late. You will stain it with steroid, clear all the vitreous which is attached, or if there is no PVD, you make sure all are cleared, and then it's a combined detachment. You can see the configuration of the retinal detachment because there is a regmatogenous element, plus you have this severe proliferative diabetic proliferation which produces, and you are using the PFCL, and I'm actually doing, as he said, I'm doing a bimanual dissection under the oil, under the PFCL, so that the PFCL hand has a third hand, and there's a break in the periphery. So you're removing an en masse, the fibrous proliferation, and then identify the break, and then go do an endodrainage, then do a PFCL air exchange, and then air oil exchange. If you want, you can send this for any studies or a histopathology or histochemistry, but right now we can't do anything more active or even in proteomics. But you can see I did a diathermy around the break, and then did the endodrainage, and then also did a fluid air exchange and completed the vitrectomy, reattached the retina, trying to remove the bleeding. But in this case, in spite of all the things, we couldn't remove most of the blood. But you have to actively follow up that patient, complete endolaser photocoagulation, and all around we can see multiple breaks that happen because of the severe proliferation. You can see multiple ports have been used, and this was the fundus picture with the 636 vision. So many times these sort of patient, you can't remove the oil, you may have to wait for longer. And this is a very old video, because I'm using a stiletto made by designed by Dr. Klaus Eckhart in 93. I think I'm doing a biomanual dissection. The idea is you can see that we're using the forceps in one hand, and as he said, precision is the most important. I have about a minute. So this is what we clear all the vitreous membranes, and you can clear the entire thing. And there's one more surgery showing the similar. This was the picture, and the idea of the biomanual vitreous surgery is you can en masse remove it and avoid any iatrogenic break. So more and more you do similar cases, you can avoid breaks, and then you will be able to save more eyes. So favorable preoperative prognostic factor, shorter duration of macular detachment, limited extent, and all this we know. So absence of RD involving macula, absence of rubeosis, and all this patient, with all this I do surgery. So I think in the 3D you can see whatever we are doing, and this is what I am doing, everybody can see. One more advantage is in the layers, you can identify the 2 layers in the full screen, which we are doing the magnification. The finer details may be lost in the regular microscope, which we can see. But for that sake, the cost is too much to pay. But I did one wise thing. That's what Maipal said when he came, that I took a donation from Bajaj, because he has diabetes and family, and they have given this, and per patient we pay the foundation. So surgery for PDA remains challenging, but has advanced due to improved surgical instrumentation and 3D vitrectomy. And recently did a very bad diabetic traction detachment with the 3D. I use artevo, but in Mexico I use the Alcon.
All the surgery you showed was
3D, but I didn't bring the thing. It's on the 2D. Thank you very much.
perfect surgeries we thought are being the conventional.
Yeah, the last 2 are conventional, because that is a 93 video. I just maintained it, because now what I did is, instead of having a stiletto, I'm using 2 light cables, so you can have more light, and we can have not only for video, but at least for the visualization and clearing all the debris.
Thanks, Nati, for adding what Himadri also showed, but these are few additions to that diabetic armamentarium. And as I said, in diabetics, it is an unpredictable job sometimes. And you have to counsel these patients very,
Yes.
very well. So sometimes you see, therefore, never hurry up to operate a diabetic. Especially if the vision is pretty good, you may see, a lot of TRD. So my criteria of entering a TRD is vision, is nothing else. Because especially if it is one eye, you never know, this patient may, have this good vision for 5-7 years. But if you intervene, maybe you spoil this vision immediately. So that has, I think, everybody has burnt fingers. So therefore, please be, empathetic to the patient rather than showing surgical heroism for doing good videos.
Yeah, it's actually putting the hand in the fire.
Yeah.
Both can get burnt, the patient and yourself, and sometimes they will fight with you or cry or go in depression.
But the reason I'm saying so is because I've seen a lot of young enthusiastic surgeon entering a diabetic eye with the 612 kind of vision,
Yeah,
and then you
not
face
advised.
5/60 vision for years. So that is what is, to me, not acceptable.
Yes, and in a yes. As in a situation where one eye is already lost and other eye is having some useful vision, and you are seeing a diabetic with a traction, it is you have to judge whether your surgery is going to improve the residual vision or not.
Thomas?
Yes, it takes almost 2 decades of practice to identify which all cases not to operate.
Exactly.
Therefore, I said, you see, till the time you have genuinely gray hairs, so till that time, it takes time to identify.
Now that's why the last chapter of Steve Charles, and I have also written in my textbook, surgical self-education. You have to be sincere to yourself. How much surgery is your surgical self-education? That means whether your experience is good in your own moral conscience, have you done the best to the patient? If you can't, why offer the surgery? They come and tell me, sir, your student is willing to operate. I said, see, he is willing to operate, but I am telling you better not to operate, because this is like this. Still you go to him, talk to him, and then I am not going to discourage you. But if you have a problem, don't cry and don't fight with my fellow.
So the take-home message in one-eye diabetic is to be conservative.
No, no, not conservative.
Yeah,
You have to
matlab
discuss in
safe.
detail.
Yeah.
See, and the second is with
No, I'm not saying-
rubeosis.
No, Abhishek, I never said be conservative.
Correct.
You see, once you are inside, you should be reasonably aggressive.
Reasonably.
But what I'm saying is pre-op decision.
Correct.
You see, in a pre-op decision, in a reasonably good vision, I'm saying.
Reasonably.
Suppose the vision is, say, 618, 612, in the only eye, I will hold my hand.
Correct.
Yes.
You see, the only indication of going in a 6/6 eye is a GRT or a reg RD.
Right.
But otherwise, the TRDs tend to remain stable for a pretty long time.
Pretty long time, sir.
Yeah.
If they are laser, then
So
No,
I
the
think,
intervention you have to be careful because with the rubeosis also I give anti-VEGF in the intracameral facing the bevel over the iris and then operate within 24 hours. All that we do, but we make sure that we discuss the patient in detail with the referral doctor, with everybody, because they will say, that patient did well and why this patient is having problem. And if they develop a painful blind eye, that's the worst. Now fortunately with steroid, with all this anti-VEGF and lasers, I think endo laser also, the NVG I am not seeing at all. Otherwise, 35 years back we are seeing NVGs.
No,
And alcohol injection, Dr. Badrinath used to give.
For 5 days back, I saw bilateral NVG.
Oh God.
Operated diabetic.
Yeah.
So don't say that we don't see. We see.
No, I know, but mostly we are doing more lasers than before.
Yeah.
So I think that way.
So I think we had a wonderful session, and time also is up.
Sir,
And
can we ask for a
let me
quick-
thank all the speakers who made this session wonderful, starting from Dr. Anusha, Manoj, Dr. Burman, Abhishek, Himadri, as well as our boss Nati, who made it very lively. So yes, Abhishek.
can we have a quick photograph with all
Yeah,
the presenters?